Welcome to On Becoming a Healer podcast. In each episode of this podcast, we talk about issues that are key to becoming an effective healer in medicine and in other health professions. We focus on how we engage with patients with a shared sense of humanity, clarity of boundaries, issues of judgmentalism, and related topics. I'm Stefan Kertes. I'm hosting today, and we have two people on with us. One is my co-host, Saul Weiner. Hi, Saul.
Hi, Stefan.
And today's guest, we have a resident physician from the University of Alabama at Birmingham, Aditi Jani. Hello, Aditi.
Hi.
The thing we're going to be talking about today is dealing with our own reactions when there is something distinctly negative and maybe even a little bit scary coming from the patient who we are charged with taking care of. As a doctor, what do we do? What's our responsibility? How do we feel? How do we manage those feelings? And that's where Aditi comes in, because we're going to begin with a story from her. So, Aditi, how long have you been a resident for?
I am a PGY3 resident now and just started my third year, actually.
So you've done it for a while, and this experience is a little bit different. You mentioned it to me in passing, but I wonder if you can kind of describe this episode, which comes from the hospital, right?
Yes. So one day I was on a inpatient ward service, and it was just like any other call day when we were admitting in a flurry, not much time to really sit down and think and process things. And I went to go see a patient. He had already come up to his room. He was a young man. I don't think he had very much past history. And he had come to the ER with complaints of excruciating low back pain. And the ER actually did an MRI and found that he had what appeared to be spondylodiscitis in his lumbar spine. And this gentleman had a very long-standing history of IV heroin use and had used as recently, I think, as maybe that day or the day prior. So presumably he had spondylodiscitis from hematogenous spread of whatever organism he may have, picked up while he was using. And this is a type of patient that I think all of us have seen before. And it's easy to sort of paint a picture in your mind of who this person is going to be like before the door opens and before you actually interact with them. And I'm not perfect by any means and definitely have assumptions and biases that I carry, but I try to be cognizant of. So I went to go see him just to interview him. And the door opens and I see this young guy there who has a Carl Sagan book on his bedside table. And he's covered in tattoos. And he looks sort of disheveled and he looks like he's in pain, like he might even be withdrawing. And I asked him a few questions, and he responded as best he could, but he was clearly uncomfortable. And that made me upset. Obviously, you don't want to see somebody suffering or in any kind of pain. And when I went to examine him, I was doing a head to toe sort of exam, and I wanted to check his lower extremity strength. And so I peeled the blanket off of his bed, and on his leg, probably the size of my hand, there was a tattoo of a shield, and it had an SS symbol and a swastika on it. And I remember at that moment, I think it took me a second to really process what I was even seeing. It seemed so discordant with the human that I had just interacted with. He was very pleasant and appropriate and really wasn't even asking me for pain medications, not really in that sort of quote unquote drug seeking way. And I was taken aback. I remember sitting there kind of staring at it for a second and then trying not to stare at it because I didn't want to seem like I had even noticed it. And then I went on with my exam and gave him pain medications, put him on methadone, tried to get him out of withdrawal and put him on antibiotics and took care of him like I normally would, like with any patient. But I think it was a few days later, actually, when I ran into Dr. Kertes, that I kind of was able to sort of process and articulate what that moment felt like to me. And the more I walked away from it, the more I sort of thought, wow, this man literally has a swastika tattooed on his leg. And that was clearly a very conscious and premeditated thing that he did. And if not today or yesterday at some point that meant something to him, right? You don't just tattoo arbitrary things on your body. And so the swastika itself, I mean, it carries such a terrible and hateful history with it. And then to have the SS symbol as well, I mean, I felt nauseated. And as a person of color myself, who has many Jewish friends, who has many other friends of various racial and ethnic backgrounds, I couldn't help but think like this man has a symbol on his leg that sort of stands against everything I believe in and work for. But it was bizarre because despite this clear symbol that he had taken the time to brand into his body, he was nice. He was a nice guy. He listened to me. He asked thoughtful questions. He was reading Carl Sagan books, which was really threw me for a loop. I guess my assumptions of him led me to believe that he was not the type of person who would do that. And he was seemed like a nice guy, a normal guy, if you will, not a Nazi. So it was really confusing because you want a part of you, at least, this part that maybe you're not willing to admit is there, wants to dislike this individual because of this, this symbol or this ideology that they seem to carry. But then there's this other part of you that just can't help but sort of like them for whatever reason. That was basically the situation.
Aditi, just so I get this clear, is it fair to say he never expressed any hostility other than the marking on his body?
I think that's fair, yes.
And the other thing is that there's this moment of shock that you had while you were examining him, and something happened to you, and then you suppressed it quickly. And I want to know, do you think that's an automatic thing that you're just able to do generally, where you feel shocked by something and then move right past it?
I think so. I think it kind of comes with the territory of what we do, right? I mean, we see and hear and smell a lot of bizarre and often offensive things. And ultimately, we have to sort of save face so as not to make the person in front of us feel judged or uncomfortable in some way. And that's part of, I think, maybe the professionalism that comes with what we do. So yeah, I think it's something that I've just gotten accustomed to, kind of maintaining a poker face, if you will.
And I'm going to guess that you never asked him about the tattoo, right?
Never. No, I wouldn't even know where to start.
I'd love to hear more about how this relationship played out. So what did you actually care for him over a couple days? Like what happened next?
Yeah. So he was admitted to my service and I was the senior resident on. And so I would round with my team every day that I was there. And sometimes when my interns weren't there, I myself would pre-round and see him every morning. So I saw him nearly every day for probably a week and a half to 2 weeks. And I think in that time frame, he sort of surprised me more and more with just how nice of a person he was, or at least, he wasn't unpleasant. I think that's probably a better way to put it.
And I'm curious, did you share what you had seen with any of the other people on the team?
Yeah, we talked about it pretty openly because it's just one of those things that, I don't know, was kind of confusing and notable. And I think everyone sort of had the same reaction of surprise, maybe, that he seemingly was such a nice, agreeable guy, would have this symbol of overt and obvious hate tattooed to his body.
I want to point out that it doesn't sound like anybody ever thought that they would stop the work of taking care of him, right? Like that was just a given.
Of course, it was never an option, I think. And this situation translates, I think, to other scenarios. And I just want to say that I'm not trying to equate Nazi symbolism to some of the things I'm about to say. But for example, taking care of a patient who is a prisoner, or taking care of a patient who's just generally speaking a jerk, or even in this day and age, at the risk of becoming a little bit controversial, taking care of a patient who has chosen not to get the COVID vaccine, who then has COVID. Again, I'm trying to be very clear that I'm not equating Nazi symbolism to these things, but I think there are so many times where we as physicians are put in a position where we have to take care of patients whose ideologies clash profoundly with our own, and trying to navigate that can sometimes be exhausting.
Doesn't it go beyond just the ideology might clash? In the case of the swastika, it could be taken as a statement about you. I'm Jewish. I could take a swastika as a statement about me. Your family's partly Indian, is that right?
Yes, my family is Indian. And I have a foreign name. I speak a foreign language. My parents have accents. So seeing something like that is offensive. I mean, it's like you clearly hate me and people who look like me or people who are similar to me in this way. And yet here you are now needing my help. And that's also an interesting sort of feeling, because then the kind of power dynamic shifts.
So, Aditi, at one point you said to me you were thinking you might show him that your kind, as it were, weren't necessarily bad or a threat. Like maybe you were going to partly influence his view of people who were not like him.
Yeah, I think that's sort of the idealist in me, who felt that maybe if in some way I were to show him that I am a good person and a good doctor who cares about her patients and wants them to feel better, that he would sort of realize that maybe this hate is misdirected. And again, I don't think that that tattoo was specifically directed at me in any way, but just the sentiment behind it maybe is misdirected. So yeah, I sort of thought that maybe I could show him by example that not all of us are garbage, I guess.
Yeah, I identify with that a little bit because I recognize in this podcast, we talk about boundaries, and that sense of, I think I need to show you that I'm not as bad as what you think I am, is a feeling that I have had. And I've had it more than once. So that isn't surprising at all to me. What's interesting is, of course, we don't know if patients arrive at the conclusions that we might fantasize they would arrive at. Saul, do you have other questions as you hear this right now?
I think one thing we all know about radicalization of sort of white nationalists is that it's a process that occurs often through kind of recruitment. You can think of somebody like if you actually had kind of a lot of knowledge about this young man, and you can sort of imagine. Again, I'm making this up. This is just me imagining a common scenario, that this is somebody who, in some ways, may have been kind of a lost soul. Somehow got roped into a kind of movement, a white nationalist movement. I mean, this is the kind of thing that happens a lot, and this is how terrorists are made too. And who knows what kind of upbringing he had. And again, I don't mean to paint a sob story here, but he could have he may have grown up in an environment where he was exposed to violence and abuse, poverty, and certainly misinformation. And despite it all, he came out. Obviously, the person you were dealing with was a pretty sweet guy, but somewhere along the lines, he got roped in, and that's where the tattoos appeared. The kind of sense of community he got from being part of this kind of hate group. And now that's not to discount the harm that these types of groups can do, but I sometimes find that once we get to know more about our patients, sometimes it's easier to become, for lack of a better term, sympathetic, as we come to appreciate that they got there in a very kind of circuitous way, and that tattoo may not represent that tattoo may not quite represent what we think it does for him. Like he may not see a cognitive dissonance between the fact that he's got that tattoo on his leg, or that his doctor is Jewish or Indian or immigrant or any of those things. So I don't know. Those are some thoughts that come to mind. I'm wondering what you guys think about that. If that's something that you think about.
Yeah, it crossed my mind that maybe this tattoo was something that he sort of got when he was much younger. Maybe he regrets it now. Maybe he doesn't feel this way or share these sentiments anymore. Definitely. I think that's reasonable. I don't know his past. I don't know his story. But either way, it's still a little bit unsettling that at some point, at least in his life, he felt the need to put that on his body.
It seems like there's at least a couple choices here. One is in my mind as a clinician, or perhaps in yours, we say, we don't know the background of this. It doesn't seem to be an operational problem now. And maybe I can entertain the possibility that the feelings that are embodied in that tattoo are no longer current. And I must say, it makes, even if it's just a possibility, it makes the care easier for me as a person. I mean, or I guess the other alternative, just to lay out the other alternative here, is that he continues to feel hateful. And if you merely asked him, or if you heard him conversing with somebody else over the phone, you would learn by happenstance that, oh yeah, he still hates groups A, B, or C. But that is something he sets aside when he needs medical care. But otherwise, that's a current feeling. And I would love to say that it shouldn't make a difference, or some version of the medical profession would say it shouldn't make a difference if they actually hate my kind, or if they don't, or if it's only in the past, or if it's current. And I would wonder at DT, maybe that's a question for you. Would it have made a difference if you had heard him on the phone saying, oh yeah, I've got this Indian doctor, and then said something negative about you without knowing you had heard it?
Absolutely. I think that had his actions sort of remained in line with that symbol of hatred, I think it would have made it a lot more difficult for me to like him. And, despite what we all outwardly sort of express or project, we, again, all carry biases. And if a patient is likable, they're a lot, I don't know if the word is easier to care for, but you're a lot more willing, I think, to go into their room and chat and spend some extra time. And sometimes I think about that, and this is sort of going off on another tangent, but sometimes I think that people we don't like or people we don't agree with, maybe they're at risk of getting less close care perhaps than someone we do like. Maybe it's just something subconscious that we don't even know we're doing. Like maybe I'm not going to open his chart as many times because I have some subconscious resentment towards him. And that's sort of a scary thought because fundamentally, I would like to think that I took an oath and I stand by that. And I want to treat all my patients the same, regardless of their background or their beliefs, good or bad. But I think it's an easy trap to fall into.
So I think that's kind of the essence of this episode. And just to kind of restate what you said, which is that the degree to which we like or dislike a patient can potentially affect the quality of care that we give them. And the question that comes from that concern is sort of, well, what do we do about that? So, I think as members of the profession, we want to provide everyone with the best care. And so what do we do when we find ourselves caring for a patient who has a swastika on their leg? And in this case, he made it a little easier for you because he just seemed like basically a pretty nice guy, which obviously helped. But let's suppose he wasn't such a nice guy. And I don't think we have to say that he was saying horrible things about you and the other members of the team. I'm not going to go that far. But just let's suppose he just wasn't a particularly nice guy and he has a swastika on his leg, the kind of thing that, we all might see. And the question becomes, how might that affect your care of him? And you sort of, I think you put it aptly, like you might not check his chart as closely. You might not, maybe come back in the evening if the nurse, I'm just making up the kind of things that happen, like going the extra mile. And so the question becomes, what can we as physicians do about that? Are there things that we can do when we find ourselves caring for a patient who we don't like?
I think that my personal practice, which again, I'm not perfect at this and it's not like I get it right every time. And it's certainly not easy. But what I try to do is sort of imagine that, you're trying to kill them with kindness, almost trying to win them over, maybe in a way. And so people like that, I feel like I try harder to get them to like me. Maybe it's me wanting to feel validated in some way, but I make a conscious effort to pay closer attention to what's going on with them because I know what my instinct is. And my instinct is to try and avoid them at all costs. As much as I hate to admit that, it's the truth. And so it's sort of that going against that gut reaction that your lizard brain has, and instead making a conscious effort to say, I am going to go in this patient's room a few times, maybe try to make some small talk or connect with them on some non-medical topic and try to win over their trust. And I think that it's kind of incredible. People that you wouldn't even think you would have anything in common with, sometimes you can find something. And I think patients like that, maybe they act that way because they're feeling very vulnerable. And so trying to help them through that might help the situation and give them the care they need.
I think you're actually saying two things that I want to tease apart because I think they're both important. One of them is, as you started out by saying, I want to kind of sort of go bend over backwards to be super nice and to get them to like me and so forth, almost to overcompensate for what my inclination is to do, which is to run in the other direction. So that's kind of one thing you're saying, which I think is important. But then the other thing that was kind of buried in there that I think is really merits talking about is that by engaging with them as a kind of fellow human and talking about things, you start to like them in certain ways because you start to find out things about each other that are human and somehow connect you to them as a fellow human and that kind of transcend the assumptions that you're making about each other. And so what that gets me to think about is kind of do you start to gently ask them questions about themselves that might give you some insight into who they are. And are you more likely to do that with a patient like this than with any other patient, or less likely, or about the same likely? I mean, I'm curious about that.
I think I would say probably about the same. I think it comes more naturally with the patients who are nice and agreeable and listen to me and take my recommendations. But the people who don't, or the people who are, just rude or seem unappreciative or complain a lot or constantly asking for things, kind of the people that we try to avoid, those I try really hard to, exactly like you're saying, ask them things about themselves. Where are you from? What did you do for work? And then maybe knowing some fact about the town they come from. If I happen to know something, I'll say it. And then they sort of relax a little bit, and then the conversation flows more naturally. And then they go from being sort of hostile to being a little more relaxed and more willing to entertain my suggestions.
Yeah, I think what you're saying, which is something I identify with, and tell me if this is what you're getting at, is that in a sense, it's almost like you're trying to find something to like about them. And I think that,
yes.
Yeah, and I think we can find something to like about most people. And in a sense that's in a sense what you're doing.
I think so. We can definitely find something to like about most people, even if it's, sometimes I admire someone's stubbornness or their, willingness to stick to their guns, or the fact that they're kind of sassy, and it's refreshing. And I try to just imagine myself in their position. I mean, the patient is so vulnerable. I mean, literally, right? Like they're wearing a thin hospital gown, and I'm constantly looking at private parts of their body, and we have to all act like it's no big deal. And then I know how much urine they've made, how many times they've pooped. I know what their creatinine is. I know what they're eating. I control their diet. I know what their insides look like on CT. So how can they not feel vulnerable?
Yeah, absolutely. And we on other episodes, we've talked about how patients in that situation can act out, and they can often become, as you describe it, sassy. And to some degree, you got to kind of salute them for that. They want to have some voice. And I think that the key here is, as physicians, we need to interpret that not necessarily as a negative, but as a normal and even kind of refreshing, as you say, response to the plight that they're in. And absolutely.
What if sassiness does trigger the impression that they may harbor hatred? What if the patient's swastika is associated with attitude and associated with a few signals that I'm not sure I trust your kind, whether it's your kind based on your color, or your kind based on my assumption that you're Jewish, or what At that moment, as a clinician, the challenge gets a little tougher, doesn't it? How am I going to survive, or how am I going to be of use to somebody who's sending me a signal, or seems like they're sending me a signal? Maybe they are intending it, or maybe they're not, that says, you're not the kind of person I expect or want here. And how do we get through that?
Honestly, I wish I had an answer. I don't think I do. I think that's when I personally, I think I run the risk of paying less careful attention to that person, which is inexcusable. It's not what I want by any means. But I guess it sort of just comes down to another question. Can you really provide good care for someone you don't like, or someone you even hate, or someone who's just terrible? I don't know. I don't know the answer to that. It's so hard.
I think it's an important question to actually push a little further, because my own view about that is, if you can't find anything to like about a person, you probably shouldn't be taking care of them, for the very reasons you mentioned. Now, I think the optimistic side of it, which I think you were getting at, is that most of the time you can find something to like about a person. I don't know offhand if I've cared for a patient I couldn't find anything to like about. But yes, I think that if you genuinely can't find anything to like about a patient, then you probably need to find them another doctor. I mean, that's just my reaction. I'm curious what you guys think.
Well, I want to accuse you of hypocrisy, Saul.
Go for it.
I mean, at some level, we've talked a lot about boundaries in this podcast, and you've spoken about the idea that the patient is not there to meet our emotional needs. And each time we talk about this concept of whether I like the patient or not, part of me is thinking, Saul has taught me to understand that the patient's not there to meet my emotional needs. So why should I have the need to like the patient? The patient's not there for that. So now you're saying this other thing, like maybe I should be finding something to like. And believe me, I know I am looking for things to like about patients. But at some level, I felt a tension about, well, am I trying to like them, or is that actually out of bounds? Is that not the point?
I'm not sure I've ever met a patient who I couldn't form some sort of human connection with. I mean, obviously, I've had many patients who've rejected me. They've just been furious that I won't give them a narcotic, and they tell me to go to hell, and they hang up or they walk out. I mean, that happens. And I'm like, okay, so they rejected me, but that happens. But I don't know if I've ever had a situation with a patient where I found them loathsome. I couldn't find anything to like about them. But I think if I did have that situation, I don't think I could take care of them. Huh. And it's not the same as they're meeting my emotional needs. It's a question of my not being a reliable caregiver, a doctor to them if I find them abhorrent. And so I guess my view here is more I think what Aditi was saying, which is find a connection, find something about that person. There's a sense of shared humanity, just so that you somehow have a connection to them, and that seems to be almost always possible.
Mm-hmm. Especially in the South, because you can always just bring up football. And,
Right.
That will usually go somewhere.
Yes.
But I think the interesting thing is it's not just the football. It's the football becomes a gateway into something a little more, a little more substantive. Just a sense of feeling like you're having a good conversation, like a sense of shared conversation with somebody.
Puts us on an equal plane. We're equal in the world of discussing football, or when an individual tells me about their military service history and I don't have that military service history, they're actually on a higher plane. So it shuffles the power dynamic a little bit, doesn't it?
I mean, I think it does that. But what I was thinking of specifically is that if let's suppose this person is a swastika and they're kind of nasty, and you get the feeling that maybe they don't like Jews or they don't like Indians or whatever, and you get into this engaging conversation about football. In that conversation, and the fact that they're talking with you, you're talking with them, you're chatting about whatever, who's going to win, teams and so forth, and you get engaged in that, all of a sudden the other stuff now is receded, and all of a sudden there is you now have kind of a positive. They've acknowledged you, you've acknowledged them, because after all, you're having a conversation about something you're both enjoying. And so I think to me, that's maybe the path. Does that make sense?
I think that's the path. And I think that you can always find something, like you're saying, Saul, to like about someone else, or if not that, then at least to connect on mutually, even if it's both of your moms are from the same town in Ohio, for goodness sake, there's something to be said.
One of the things we're hoping to do with this episode is to kind of give some food for thought and maybe some guidance to other physicians, residents, medical students to think about what to do when you find yourself caring for a patient who has a symbol of hate, for instance. And I think some of the themes that we've talked about are one of the most important themes, I think, was almost like leaning in, getting to know them a little better, because that's one of the ways in which you form human connections. You begin to maybe care about them, and also they may become more comfortable with you. What are some other thoughts or themes?
Two lessons I learned from this conversation. One is that our own reaction to those symbols does represent a point of risk to care. And Aditi seemed extremely conscious that there was a chance that something could go wrong in the care unless she was mindful of her own reactions. And I think that is a very helpful lesson for all of us to recognize the moment we're feeling that negative passion of, oh my God, what's going on there? That's the moment to say, there's a chance I won't pay the attention to this patient. I really need to. And the other comment that I think I've realized here is that a lot of our conversations with patients that we refer to as small talk actually is big talk. And that these moments where we share something with the patient that maybe is not directly relevant to the clinical evaluation, but is part of forming a human connection, is actually very important to successfully getting work done and perhaps to our own enjoyment of the work that we are doing. So whether it's football or I guess in a different place, the kind of food you like to eat or military service history, those things can connect us in ways that set back the potential lines of political or cultural fission that otherwise would be there.
I think that ultimately it's all about sort of recognizing that bias creeping up behind you and then choosing consciously to combat it in some way, whether that's by bending over backwards to try and find a point of connection or just forcing yourself to go into that person's room more times a day than you normally would. I think that we have to be above some of those feelings when we're caring for others. Right now, I can just give you a quick example. My colleagues and I are working long hours in a COVID ICU, and the vast majority of the patients that we're seeing are unvaccinated. And it kills me. It kills me because I've lost family members pre-vaccine to COVID under really unfair circumstances. And we would have given anything at that time to have them vaccinated and to be vaccinated ourselves. And now when I see these people who had that choice and chose not to take it, I worried going into this rotation, would I be able to cultivate sympathy for them? Would I be able to care as much? And then when you actually meet these people, a lot of them were victims of misinformation. A lot of them weren't educated enough to understand some of the kind of finer points of the vaccine and that it's safe. A lot of them didn't have access or a car or a way to get to a vaccination site. And I think in those moments when you sort of hear their story, like a lot of them are just normal, nice people who are trying to live their lives and didn't really have any sort of political motivation behind not getting vaccinated. They just didn't think it was, I guess, that big of a deal. And here they are, sick as stink, being proned. And it's hard not to feel for them. You can't not feel for them. At least I can't. And so sometimes when I read these articles about physician burnout and this new wave of the pandemic where physicians are saying things like, I'm having trouble sympathizing. I get that. I really do. I get that. And part of me almost even wants to feel that way because I'm tired and angry and frustrated that this pandemic is still ongoing, just like everyone else is. But at the same time, I mean, these patients in front of us, they're someone's dad or someone's brother or someone's mom. I mean, there's someone, right? And you want to care for them as if they were your someone, or you would hope that if your own loved one was in the hospital, that some physician would care for them like they were their own family. And so I try really hard to come at it from that approach. But again, that's a conscious effort. It's not something that always comes easily.
I identify with that. I've spent a lot of time as well talking to patients who refuse to get vaccinated, and they're not in the ICU because that's not where I work. But I have these conversations several times a day. And similar to you, I found myself becoming, maybe sympathetic is too strong a word, but before I was really hostile and just pissed off. And now I do sort of to some degree just feel sad. I realize that these people, and I think you summarized all the reasons well, they're just trapped in some sort of veil of ignorance. And in some cases, they're beyond reach, like you can't even talk with them about it. And they're trapped in some sort of weird distrust of the system. They have a different view of reality than we do. I can't quite grasp what's going on, but I can tell that it's deep and it's unreachable for some of these patients. And others, as you say, it's just there's just a lack of trust, misinformation. There's so many reasons, but whatever it is, they're doing the best they can. I mean, this is the world they're in. And yet they're the ones who are suffering, or who are at high risk of suffering in the cases of the patients I see. So I do find that just the more I care for these patients, the harder it is for me just to feel anger. And instead I just feel kind of some sadness, some frustration, but not the anger and that I felt early on. And I think that might be a little bit of what you're conveying.
Absolutely. I think I went into it thinking I would be angry.
Yeah, and you start that way. So I think just to in terms of closing lines, a couple, I think the key point that for me came out of this is, first of all, something we haven't said, which is that one of the privileges of medicine, and one of the reasons we all went into it, is we do have an extraordinary opportunity to have contact with all kinds of people who, are most of our professional colleagues, people from we went to college with, don't get to do. Because we're physicians, we cross paths intimately with, somebody who has a swastika on their leg, for instance. And that's, in some ways, that is the privilege of medicine. And, although it can elicit in us initially a kind of shock or withdrawal, ultimately, it's an opportunity to get to know that person a little bit, to form a connection, and maybe to realize that people are multidimensional. And I think the same thing kind of goes with patients who are refusing COVID. That's not just what defines them. It seems like if there's any lesson to pass on to medical students and residents here, it's lean in. It's get to use that privilege that we have as physicians to actually get to know that person and form a human connection. I mean, I don't want to put words in Stefan's mouth or DT's in your mouth, but it seems like that's kind of the message here. Would you guys concur?
Yeah,
absolutely. I think, Saul, you put it beautifully. We are in a unique and privileged position as physicians, and we should use that to try and connect with people and provide excellent care for them. And I think lean in is probably the best way to put it, really.
And I also very much appreciate what Aditi said, which is each person is someone's someone, and we should try to take care of them like they are our someone. Thanks both of you so much for this time.
Yeah, well, thank you guys.
Thanks so much for having me.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.